Well, it is my privilege to introduce Dr. Kyle Page. Dr. Page earned his doctorate in counseling psychology from the University of North Texas in 2013. He completed a postdoctoral fellowship in clinical geropsychology at the VA Boston healthcare system. His area of clinical and research experience includes geriatric mental health care, long-term care, non-pharmacological dementia interventions, decisional capacity evaluations, and staff training. At the VA Medical Center, Dr. Page provides therapy and geriatric assessment services to older adults in outpatient care, physical rehabilitation, long-term care, and hospice care. He currently serves as co-leader of the VISN 19 Dementia Committee and is newsletter editor for the Psychologists and Long-Term Care Organization. Dr. Page is a real treasure for Wyoming, so which I know you'll find during his presentation. So welcome, Dr. Page.
Thank you. This pulls out. Good morning. Okay, is the level of my voice okay? Okay. I tend to be a loud speaker anyway, so if I move away from the microphone, I'll make sure I remember to project. So again, my name is Dr. Kyle Page. I usually just go by Kyle, and that's fine. And I'm what's called a geriatric psychologist. And we're still pretty rare that I wouldn't be surprised if it might be a new term, but you can understand the word geriatric. Most people understand what the word psychologist means. Everything I do in my life is mental health care with people over the age of 65. That's all I know. It's all the training I received. And it might be something such as the difficulty with stopping driving, or what it's like to transition into a nursing home, and all the high school politics that come back up when you do that. There's lots of gossips in nursing homes. But those kinds of issues, as well as depression, anxiety, trauma that comes in later life. But a big part of my work is with dementia care. And how do you help someone, whether it's in the home environment, if it's in a medical unit or a long-term care unit, how do you help someone transition the best that they can, help them with the brain impairments that they're having so that we can avoid, at all costs, any kind of medication, if possible. Giving all the side effects that we've heard earlier today. All right. So what I've kind of planned out for you today, we do have a longer presentation, and dementia basics was just covered right before by Dr. Woods. So I'm just going to real brief emphasize some of the points that she made, because I think it's going to be important when we get to talking about behavior and communication specifically. Okay, so we won't belabor on that too long, but I want to point some things out about dementia in the brain. Just we know repetition also helps remember things, so I'm going to do that as well. And then I need to give my disclaimer, because I guess I didn't put it in here. So my bio does include, I am a psychologist at the VA Medical Center, but I am required to let you know I'm not working today. And so anything I say isn't any official position of the VA Medical Center, and certainly I don't speak for the US government. But I promised my ethics committee I would always mention that when I'm not working. So this is just me and my training that I've received. All right, so we're going to talk real quick about this points to emphasize for dementia. Talk about different kinds of behavioral changes and psychiatric changes that can happen when somebody has one of these kinds of dementias, as well as how we would encourage anyone to start thinking about behaviors and start describing behaviors that you may be seeing in a loved one, in a patient, or whatever settings that people come from. There's a language we're trying to encourage people to use rather than just saying agitation. Okay, agitation does get the point across, and I realize that there's probably stress going on and someone's not happy, but it doesn't tell me if you're getting kicked, if you're getting spit on, if they're not taking meds. And so we're just going to talk about that, just different vocabulary words to use to help the treatment team and to help you just kind of clarify what you're experiencing. And then the last half of our talk, we're really going to focus on what I've outlined as foundational dementia skills. Okay? Everyone in this room comes from different backgrounds, different levels of experience and exposure to dementia care. And so it's kind of hard to pinpoint for each person. So I'm just going to go with some basic foundational skills that are important that don't get discussed a lot whether you're a family member or a healthcare provider. So we're going to spend a lot of time on that actually as well. All right. So as part of this review that I promised, I always like to emphasize there is a difference between dementia and the word Alzheimer's disease. Okay? And so a lot of times when I'm speaking and I'm working with families, I'll interact with somebody who says, what's the difference? I don't know what the difference is. People use them all the time. I don't understand. And so what I've outlined is dementia is really just a really general, broad term that means you're having trouble. Right? And that trouble is in some area of your brain is not working well. Right? It could be memory, but it doesn't have to be memory. It could also be language, the way you speak, the way you understand words. It can be your ability to focus and pay attention on something. It can be how well your eyes and your brain is able to judge how close I am to a table and not bump into it. Right? So the word dementia just means some part of what your brain can do is not working well anymore. And it's above and beyond just growing older. Okay? So we account for that. We have ways of accounting for that when I meet with a family or someone who's wondering if they have dementia. So in addition to that brain trouble that you're having, that causes day-to-day life trouble. Okay? And so Dr. Woods kind of gave some examples. Classic ones people tend to hear are going to be things like trouble driving, trouble managing the checkbook, right? Forgetting to pay bills. And those are things that people, I think, readily recognize as trouble. But with some of the dementias, they do get worse. Okay? Not all dementias get worse, but that's a whole other topic. The dementias that do get worse, by far most of them, it's going to get to a point where it's trouble knowing what a shirt is, how to put a shirt on, how to get the fork into the food and then figure out how to get it to my mouth. Like, we're talking about that kind of day-to-day life trouble that people will experience. Okay? That's all the word means. All the word means. And so when I meet someone and they say, I have dementia, or I think my family member has dementia, naturally in my role, I'm always asking, well, what kind? Do you know what kind? It's not easy, right? So a big part of my job is to try to figure out what kind of dementia somebody has and all the tests that I do. And it's not always, it's not like I sit with you for 5 minutes and can figure it out. It's actually pretty hard. But it's important to know because with Alzheimer's disease, which most people hear about, we know that the brain trouble classically tends to be memory. In fact, when most people hear the word dementia, they think of the word memory, right? But that's not true. Again, you could have language trouble, you could have attention trouble, and memory would be just fine, right? So where the difference between dementia and Alzheimer's is Alzheimer's really refers to a specific cause of dementia. So when we're saying this person has dementia, they have brain trouble, and they have day-to-day life trouble, the natural question is, what's causing that trouble? One cause is Alzheimer's disease, but there are many other causes. Many other causes. Okay? So that's just generally the difference. We also know with a lot of the dementias and what this presentation is going to be about, there are some emotional and psychiatric changes that happen as well. It doesn't have to happen for some of the diagnoses of dementia, but it's so frequent that it should be something to be thought about. It should be something that family members are prepared for and talk about just basic ways to kind of handle when that comes up. Okay? And I talked about many different kinds. When I talk to people, I usually throw out a fancy number like 50. There's like 50 different kinds, right? A lot of those are really rare, and I'll probably never see them in my lifetime. But the top ones are going to be things like Alzheimer's disease, vascular dementia, frontotemporal dementia, which actually has about 3 different kinds, and Lewy body's dementia. Right? Those are usually the classic 4 that I talk about, which when I'm with families and stuff. What my presentation is going to focus on today is kind of big picture dementia. All right? So I'm not really going to break it down to if it's Alzheimer's, then this. If it's Lewy body's dementia, then this. We're thinking big picture, foundation, just how to understand behaviors and how to interact with somebody. Okay. I believe this, a smaller version of this picture was in Dr. Wood's slide set as well. Maybe it went down at that point. But I always like to show some picture, obviously not a real picture of the brain, but an artistic picture. Left versus right, one's healthy and one is not. The one on the other side is an Alzheimer's disease brain that's pretty severely progressed. Okay? And for a lot of people, they understand that the brain's having trouble, but it's another thing to show someone a picture of the brain, right? Clearly, we won't do Q&A, but clearly the brain is shrunk, right? That's what Dr. Woods talked about, how a lot of the brain cells and neurons are dying by various reasons, depending on the kind of dementia you have. And that causes a lot of trouble. And what I've highlighted here, because I think it's important to note, there's a very particular part in your brain that's responsible for making a memory, right? Not storing it, because that's throughout your entire brain, but making a brand new memory. So when I came up here and she said my name, you made a memory, hopefully, that my name was Kyle. If not, then I'll be sad. But it went to a very specific part of your brain, right? And we won't get into the technicalities, but I've highlighted it on a picture of this brain. And this picture, just to kind of give you some orientation, this is you're looking straight on into someone's eyes, essentially, straight on into their head. And it's about not quite halfway through, just straight down. Okay? So you have memory. I'm going to point this out and hope it doesn't mess anything recording. Right here. And then you try to find that on the other side of the brain. Where is it? Right? I mean, I guess we could probably say, oh, maybe around there somewhere. But it's gone. It's simply gone. This is still someone who could be alive, can still interact in some way with you, still maybe feed themselves. Right? But that part of the brain is just simply not there with Alzheimer's disease. And this comes up when we talk about behavior and communication, because I run into a lot of individuals that they try so hard to make someone remember something. Right? Come on, we talked about this yesterday. We're going to dinner at blah, 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 blah. Right? And it's a big discussion by pointing out, like, it's not there. The part of the brain is not there that makes memory. It doesn't mean they forgot things from long ago. Okay, or that you owe them $100 or something, right? Because that's stored in somewhere else in the brain. They just can't make a new memory. Okay, that's important to point out when we talk about behaviors. And then the second piece is language. Roughly in that part that I highlighted, you go over to the Alzheimer's disease brain. Also, generally speaking, it's gone. It's gone, or at least it's severely atrophied or shrunk away. Okay, and we'll come back to that because that's also important that with many of the dementias, there's a language impairment. It's well known with Alzheimer's disease as you get into the progression. There are other kinds of dementias that start with a language impairment and not memory. So it can be real confusing for everyone to say, well, I don't have dementia because my memory's fine. That could be true that your memory's fine, but you could still technically have dementia because some other part of your brain is not working. The definition just means some part of the brain's not working. It doesn't say anything about memory. And so I always like to clarify that up front. That's the difference between dementia and Alzheimer's disease. Alzheimer's is just one cause of dementia, and there's many more. Okay. All right, so that's my, in a nutshell, review of dementia that I just want to point out. Okay, and let me just go back to the picture. One way we try to have people conceptualize this is that the brain is sick. Okay, so when you're working with a family member, well, you are working, but when you're with a family member or you're with a patient perhaps, and you get some kind of behaviors and they're yelling and they're cussing at you and they just seem mean, right? We try to remember that the brain is sick. The brain is sick. Just like the heart can be sick, your lungs can be sick, your eyes can be sick. It's a different organ, right? The brain is sick. Right? Okay. So when we talk about behaviors, I also find it helpful just to kind of mention dignity, okay, and what the experience is like for someone who's living with any of the dementias that we talk about. Right? Now, on my slides, if you're following along, sometimes the answers are already there for you, so no cheating, no looking. But what would you say, based on what you've seen and what you know, what you've experienced, what might contribute to lack of dignity with someone who has Alzheimer's or any of the other dementias? Yeah.
Loss of independence.
Okay, so loss of independence. Other thoughts or examples? Needing assistance with private activities, bathing, grooming, cleaning, okay, toileting, right? Having to have somebody there with you. Other thoughts, things that you've seen, things that you've heard?
Getting dressed.
Okay, so needing help to get dressed.
Having someone talk for you.
Having somebody talk for you. Right, in my setting, when I'm interviewing a family, to evaluate for dementia, you'll find some family members, not all, but some family members are they want to support and they want to help and they talk the whole appointment, right? And then that person never gets to say anything. Even if they can't, I still always give them the opportunity to try to say something, to feel like they're saying something, even if it comes out and makes no sense, right? At least they're still going to pick up that they're being heard, that you're attending to them. Okay, so a very good point. Other ones, just before I pull up my list?
Inability to sign their name.
Inability to sign their name. Very true, very true. And if you can't sign your name, who are you? Right? Yes, sir.
An awareness, maybe vague, that one's independence is gone.
Yes. So awareness in some sense, at some level, that one's independence is gone or is actively declining. Like you can feel the day that your children take away the keys, or you catch them disconnecting the battery in the car, right? Some people are very aware of that. There used to be this really old sense that the difference between depression and dementia was people with dementia had no clue. People with depression knew when they complained about memory. It doesn't play out. Like I can tell you in all the families that I've seen, they are very aware that their brain is not working right. Maybe they can't explain it as well as we would hope they could, but they're very aware something's not right. Okay? And so just let me pull up my list. Very good points. These are just some, not exhaustive, but just some that I put up there as well. We do run into things like the brain is declining, right? That's part of the dementia experience. So I can no longer speak as well, or I can't remember what you just said when the appointment started. And gosh, it's really embarrassing to ask again, what did you say? Or actually what you're going to find is probably more in the social setting. Maybe they're part of a card group or a dominoes group or something like that, and they can't keep track because of memory, right? It gets real embarrassing to have to ask someone to repeat. Okay? Not everybody has that trouble, but a lot that I encounter. There's a lot of physical declines that come with the dementias. Okay? Some dementias have a big motor component with tremors and difficulty walking, okay? At least early in the disease process as well. The doctor's appointments, we're going to poke, prod, and do all kinds of things to you. Okay? We give memory tests in the appointment, and maybe they're short memory tests where it's only 5 minutes. Mine are much longer than that. But that experience of being confronted with the fact that I can't remember 3 simple words that you just told me, right? And especially as things are unfolding and you're starting to figure out what's going on. And so that can be very embarrassing. Behaviors that come up that they cannot control, okay? Cannot control. Social changes. People get awkward around individuals with dementia. I don't know how to talk to you because I don't understand what you're saying, and so they tend to withdraw, right? And they have less social contact, or less enjoyable contact as a result. And then the environment, which includes us as caregivers, and how we talk to someone and approach someone who has dementia. So there's a lot of things that factor into this, okay, when we start talking about behaviors. Okay, I do just want to kind of get the brain flowing here. You guys come from different settings, different backgrounds, different experiences. What kinds of behaviors do we know or have we seen that can happen with any of the dementias? What kinds of things have you seen? Okay. Mm-hmm. Hallucinations. Being repetitive, so asking the same question or saying the same thing over and over. Yeah. Constantly losing things. Keys, all kinds of stuff. Yes, sir.
Severe paranoia,
Mm-hmm.
mixed with hallucination.
Yep, so he says severe paranoia, and these are usually thoughts that someone's out to get you, someone's trying to harm you, you're stealing my money, you're cheating on me, and we'll come back around to that, but yes, paranoia as well. Delusions, very good point, related to paranoia, so these are false beliefs. That a delusion that's not so, doesn't sound so mental healthy would be something like your parents are still alive. You believe your parents are still alive. Or you believe that you're 40-something years old again when you might be 72. Right? Those are false beliefs. But it could also be there's a car out there in the parking lot and I'm pretty sure that they're spying on us. Right? That paranoia thing as well. I heard, go ahead. Okay, some obsessive-compulsive-like behaviors, which I'll throw in there, hoarding as well. So people like to hoard all kinds of stuff. I found people hoarding pizza and food and all kinds of stuff. And then I think there was another over here somewhere. They want to go home. Okay, they want security and comfort. Okay, so there's a lot of different experiences that can come up, and not that this presentation is meant to shock or scare someone, but it is important to be aware of the changes that can happen. And just kind of where do you go from it when it happens? Okay, so what I have up here is that across all the dementias that exist, right, Alzheimer's and all the other ones, about 92 actually percent of them have some kind of challenging behavior. Some kind. So all these examples you gave. So what usually I try to prepare people for is rather than worry about the 8% who's not going to have something, be prepared for something. Well, we also know of all those people who have a behavior, they have more than one behavior. So it's not just the paranoia, but it could also be the obsessive compulsive. It could be the memory trouble, the repetition, always asking the same question, right? So what this is saying is that it's very complex, right? It's not going to be an easy fix if there was one, right? And there's a lot of variables to keep track of, right? The most frequently reported challenging behavior is, any ideas? I just see heads going like this. Well, what would you think is the most challenging for a family member? Behavior.
Forbidden words.
Oh, forbidden words? Is that what you, yeah, yeah. Everyone becomes a sailor in the process. Yeah, which can be very shocking if you've gone your whole life and been very proper to suddenly hear all kinds of choice words coming out of somebody's mouth. Very true.
Teenage boys can enjoy that.
Yes.
How about repeating themselves?
Okay, repeating themselves. Yes, sir.
Trying to resist your effort.
Mhm.
For example, had a grandfather-in-law
Sure.
who broke a hip and needed assistance going to the restroom.
Sure.
But he, on one hand, he didn't want to use the urinary catheter.
Sure, sure.
And on the other hand, he cursed me up and
Yep.
down and right side up and
Okay.
backwards.
So-
I had to take him back.
That's right.
You know, what he wanted was not to have a broken hip. and
Correct.
to be able to go to the restroom.
Correct. And so what he's describing is resistance or difficulty accepting care or understanding care is the way I would phrase it. And then, yes? Leaving, wanting to leave, right? And so, I'm sorry? And actually leaving, right? So wandering, right? And there's different kinds of wandering if you want to get technical about it. There's people who just aimlessly walk around, but there's other people who specifically want to leave. I am getting out of here, okay? All kinds of things. Yes, go ahead.
See that wondering if they live on their own?
Usually if they're living alone on their own home, by the time I see it is APS, Adult Protective Services, or the police have picked them up, and yeah. And interestingly though, I've been fortunate to work in many different kinds of nursing homes and rehab centers and long-term acute cares, and just it's always been in the hospital setting. I've met many men who the first sign that something was off, like behavior, they were mowing the lawn at night naked.
No kidding.
Right? It's encountered more times than I would think I would encounter. But you'll get things like that, right? Before someone might notice the memory trouble, because they'll say, well, they're just getting old. You're supposed to have memory trouble, right? Which is not all true. All right, so the reason it's blank, right? There is no answer because it's very personal. Some people have great amounts of patience. Others, it's a struggle. Okay, so what's a challenge is going to be very personally relevant. What I hear in my setting, it's more of the physical types of aggression, the hitting, the kicking, and things like that. That tends to be the most challenging. Okay, the most frequent behavior is actually apathy, doing nothing, lack of energy, lack of motivation, lack of care, because of a brain reason, right? It's not like, oh, I don't care anymore. It's the brain won't let them care. But usually that doesn't get talked about because if you're not hitting or screaming, we'll just leave you alone, right? But that certainly places someone at risk for increased depression, right? Which is also a concern. Now, I do want to point out, I don't call these problem behaviors specifically. You'll hear that sometimes when people talk, or you'll read that some places. The brain is sick. It goes back to the brain is sick. They're not pre-planning, how am I going to make your life miserable today, right? The brain is sick and they're doing the best that they can. So it's a challenge, not a problem. Okay, so the big question is, where do all these behaviors come from? Right? All these examples that were given, how do they happen? Where do they come from? It gets way more technical than this, but I figured with my 4 fancy circles this would be enough. It's a combination of things. We've already mentioned behaviors in dementia is complex, right? Most people have a behavior. Most people have more than one behavior. Many things lead into whether someone is going to hit or cuss or something like that. And the way we just try to break this down to give you a sense of it is that, I'll start in the top, that the brain is declining, right? Your abilities are declining, but also structurally, the brain, the matter is declining, is going away, it's atrophy, right? So there's literal changes to the brain that by itself just produces a lot of these behaviors, right? You can imagine that if I have trouble remembering what you said in the span of our short conversation, and I don't realize that my memory isn't that great, right? Why do you keep telling, like, why aren't you telling me this would be my frustration. And you would be there sitting like, we've already been over this, Dad, right? 5 seconds ago, I just told you, right? And no matter how caring you are, at some point, it's going to get very frustrating, right? And that gets communicated non-verbally to the person, right? Who doesn't remember that you've been talking about this for 10 minutes. Now all they experience is you're mad at them for no reason, okay? So there's brain changes that are happening. Also, we always point out that there's personality and ways that people cope with stress. Okay? Everybody has your own personality, who you are, right? And we don't need to get into the fancy psychology of it, but you are you, right? There's a lot of things that made you, you, right? The upbringing that you've had, and then this all kind of leads into just kind of your preferences, your likes, what you do throughout the day. You also have a way of handling stress, okay? When I'm stressed, I like to eat ice cream. Okay, anybody else? Okay, some people, okay. My dentist loves it because it just furthers his bill. But that's my way. Also, in a more healthier way, I do eat a lot of ice cream, but in a more healthy way, I like to ride my bike, right? My road bike, as long as I don't think a truck is going to run me over in Cheyenne. But I can do that. Somebody with dementia whose brain is declining still gets stressed about everyday stuff that we get stressed about. But the brain can't figure out how to de-stress anymore, or not as well, right? Someone who's a wander risk and might not know how to come back home, they can't go ride the bike. And maybe that was their lifelong way of handling stress, right? Also there's some people that just don't handle stress at all, no matter what. They grow older too, and they also get dementia, and so it's a bad combination. Right? So you lose your ability to de-stress yourself in the way that you've done your whole life. That happens as well. You have declines in physical functioning, like you might not be able to walk as well. You may have a catheter to kind of help the urine come out. I guess we won't go there. But you have declines in physical functioning. Okay? And now if that's happening, I can't get up and take a walk when I'm stressed. And what are you supposed to do in that sense, and when that scenario comes up, right? So a lot of things lead into a behavior happening, as well as what I've called environmental stressors. And I don't mean pollution or anything like that, but is it too hot? Is it too cold in the room? I can't walk. I can't figure out how to put a shirt on to get warm, okay? Because of all these things working together, right? Is it too noisy? Is it not noisy enough? Meaning, are you bored, okay? Also, environment, I include all of us. We are part of their environment. And a lot of things that we do and how we talk and interact with someone definitely can play into a behavior that happens. Okay? Now, we can't do anything about the brain changing, right? Despite the medications we've heard about and this Prevagen that I've been hearing about over the past few weeks. It's not going to change the brain. You're not going to pump back in more brain. Okay? You can't teach someone brand new coping skills if they have a memory impairment. Okay? You can't magically make them walk again. And so a lot of this we cannot control. And so the big piece and the emphasis where we push people towards is this environmental piece. How do you make their surroundings more appropriate for where they're at in the disease process? Okay? So it's complex. Lots of things play into this. Right? Now, what I'm going to offer up here are just some different ways to describe behavior. Right? And like Dr. Wood said, there's no test, right? I'm not going to quiz anyone on this, and you're not expected to remember every single word. Nobody could. Right? But when you're working with a patient or you're working with a family member or a client or whoever, it's real helpful to the treatment team, whatever that may be in primary care or wherever, to have a better understanding of what the experience is like for you. What are you seeing with your loved one? What are they exhibiting? Right? What are their signs? And what comes out is usually, well, this person is just out of control. This person is agitated. Right? And that's a great way to communicate how much stress and frustration and how much of a challenge this causes you. But again, it doesn't tell me, are you getting hit? Are you getting punched? Or is it they're just being repetitive? Lots of people lump that all together into agitation. And I'm going to treat it different ways depending if it's them being repetitive or them hitting you. Right? So it's very helpful to have a vocabulary. Now, big picture, there's all different kinds of behaviors. The model that I use in my practice, there's about 29 different kinds of dementia behaviors, right? We're not going to go over those 29, but I'm going to give you the big picture categories. There's behaviors that are verbal, right, out of their mouth, but they're not aggressive, right? And I'll give you examples of these. There's also behaviors that are verbal, but they're aggressive. They're cussing, okay? How dare you put me in this place? I hate you, all kinds of stuff. You have a whole other group of behaviors that are physical. They're doing something. There's movement involved. But it could be aggressive or not aggressive. Right? I'll break this down. And then there's also these emotional and psychological or psychiatric components that are part of the disease process for many of the people. Right? So big picture, if you're not into more vocabulary words in your life, which is always a good thing for the brain, I would just focus on these 6. So when you're talking to the doctor, you're talking to other family members helping care, focus on, is it verbal, is it aggressive, is it physical, is it not aggressive? If you keep it there, that actually tremendously helps a lot. Okay? Now let me give you some examples. Verbal behaviors, like I said, can span from aggressive to non-aggressive. Okay? Some non-aggressive is going to be the complaining, being negative, repeating sentences or questions over and over again. Right? They're generally not meant to attack someone. And they generally don't purposely cause harm to someone, like cursing would. Right? But it's just every 5 minutes them saying, where are we going? Well, Dad, we're going to go out to dinner. Okay, and you keep driving. Where are we going? Well, Dad, we're going out to dinner. Where are we going? Right? I've been with individuals that the memory span is maybe about 2 minutes. And every time when I'm meeting with families, every single time I will always reintroduce myself every 2 minutes. Every 2 minutes, right? And it's really hard to be okay with doing that, right? But that's something we try to teach. That's a resilience thing. But it could be non-aggressive. And then there's the aggressive side, right? There's an anger outburst. They're cussing, they're yelling, shouting, all kinds of stuff, okay? So, and verbal sexual advances. Sometimes it's taboo for people to mention when that's happening, but that certainly is a part of the experience for some. So these are just a whole range, and there's more details for the behaviors as well we could go into, but somewhere along this spectrum. Now, why this is important for 2 reasons, or 2 reasons why I'll mention. One is it gives me as a provider a sense of which one do I need to focus on. I'm more concerned about you getting cussed at or sexual advances than I am about them repeating their question every 5 minutes. Because I need to target how am I best going to help you in this appointment that I have. Okay, so it gives me a sense of hierarchy. Also, what we know is that people who experience these verbal behaviors, it's usually related to some kind of loneliness or discomfort. Okay? Not 100% of the time, right? Because there's all kinds of things that create a behavior, but we try to encourage people to think about that first. Is it an issue of loneliness? Verbal behaviors make people come towards you. Okay? And this is just something that's been studied for a number of decades, actually, by Yiska Cohen-Mansfield, and so in nursing homes and all kinds of stuff. And that's what she finds, is that that should be at the top of the list when you're trying to think about the behavior. Okay? It could just simply be a urinary tract infection, right? But you want to be thinking about the loneliness aspect or a pain, discomfort aspect as well. Okay? Physical behaviors, again, just more vocabulary words to be mindful of. They could be non-aggressive, such as they're pacing, they're wandering, or what we call shadowing, right? No matter where you go in the house, they're coming too, right? Doesn't matter if it's the bathroom. And so they just follow you around the whole time, the shadowing, okay? But it's not aggressive, right? You're not getting hit or anything like that. They're just following you. They could be taking all their clothes off, putting lots of clothes on, all kinds of things, and I guess I don't have to read them all. I do want to point out handling things inappropriately, just to clarify that one. You'll notice that some individuals will just touch everything. Everything they walk by, everything in the house, they fidget and touch everything. Right? In some environments that I've been in, like in a medical setting, I've seen people break the sink off the wall. I've seen them rip the little, I don't know, I was going to say spigot, but it's not spigot. The faucet piece off the sink. I've seen them tear down curtains. I've seen them break little oxygen things off the side of the wall, and they were never mad. There was no yelling, no throwing, no nothing. They were just touching everything, and this person happened to be pretty strong. Okay? So that's what I mean, like they're just touching all kinds of stuff, but they're not upset. They're not distressed. Okay? And then I'm going to point out the hoarding and hiding things. Okay? Doesn't happen to everyone, but you'll notice I've heard examples of people in nursing homes that will take everybody's shoes. They'll go into all the rooms, take everybody's shoes because they're their shoes, and they don't know why they're in other people's rooms, and then they go hide them in their room. Okay? I've also worked with individuals that every chance they get, they'll pocket any food item, stick it in their pockets, and then they would go stash it in a couch. They would just shove all kinds of things into the, and they never ate it. And we, I kid you not, would find slices of pizza shoved into the couch cushion. Okay? And so they're hoarding, they're hiding things. Okay? It could be with food and shoes. It could also be with money. Right? I've met a number of families who said, you know, I have no clue where their wallet is, and there were credit cards and all kinds of stuff in there, and they hid it somewhere because of maybe some paranoia was going on. Okay? And then you don't know where it went. But those are non-aggressive, right? And then you have the aggressive side, the hitting, the kicking, the scratching, all kinds of stuff. Okay? Yeah, spitting, I really need to probably put more on, well, we'll keep it physical. Sometimes people would argue that's a verbal one, but it's physical, or it's aggressive nonetheless. But you'll get these kinds of behaviors as well. And this is what most people are worried about. This is what is most challenging for caregivers and for staff in all these different hospital settings. Okay? Now, this is also important because in the grand picture of things, I'm less concerned about the physical non-aggressive, unless they're getting out of the house, right, walking across traffic or something like that. What we know is that these types of behaviors are usually related to boredom. Boredom. They don't have enough to do. They don't know what to do. They want to do something. Just because you have dementia, you don't lose the desire to want to be productive, to want to have worth, to want to show that you can help. Right? And so a lot of these times we think of these behaviors in that context. Right? So generally speaking, this wouldn't be something you medicate, those types of behaviors. In the nursing home settings that I've been in, if someone's wandering up and down the halls, I say, so what? Right? If they're not going into somebody's room and they're not getting out the door, then I kind of don't care. Let them wander. Let them explore their environment. Just make it safe for them. Okay? And then, of course, we're really concerned about the aggressive side. That's usually the highest concern I have for somebody's well-being, the person with dementia, but also the caretaker. Okay? Those behaviors tend to be related to pain and or what's called a perceived intrusion. Okay? So pain or perceived intrusion. That should be at the top of your list. Doesn't mean there's 100 other things that could be causing it. But the piece with perceived intrusion is going to be you can't fix, right? So, and in the perfect context, I give this in my nursing home setting, and I think this will easily relate to a home setting, is you have someone who lives in a nursing home that fights tooth and nail every day when the nursing assistants try to get them dressed or try to change their brief, right? Every day. Punch, all kinds of stuff. I've seen people sent to the ER, all kinds, right? That's what I mean by a perceived intrusion. To them, they're in their bed, they're in their home, they have no clue they're in a hospital, they have no clue who you are, and all of a sudden, you come and try to take my pants off and change me. How scary that is for somebody. You are so intruding on my life, my body, right? And no matter what you say, I'm a nurse, I'm here to help you, whatever, it doesn't matter. It's never going to get across at some point. So every day their experience is that they're being assaulted, right? And so it's very natural to have dementia behaviors because of that experience that they have, right? And that's why it hurts me to hear people say, or staff, not family, but staff to say something like, they're refusing to get dressed. And I say, well, to them, you're assaulting them, so I could see why they're not going to cooperate, right? It doesn't make it okay that you get hit, right? We try to find ways around this, but we just try to enlighten that experience that they're having. Okay? And then there's that last category was some emotional and psychiatric behaviors. We won't split hairs if it's a behavior or not, but emotions such as being depressed, being sad, being tearful, being frightened, being anxious, being nervous, that's all part of the experience. Okay? Now this could be, just to give an example, this could be depression because I notice my brain's not working. I notice you've put me into a nursing home, right? So there's a reason that they're upset, they're sad, they're depressed, but there's also chemical changes happening in the brain, right? So it's not like they're going to sit there and say, well, I'm depressed about this, and then you do therapy with them. There's an actual chemical change that's happening that makes people depressed as well. Okay? And then there's these psychological or psychiatric things that can happen that you all had mentioned, hallucinations, right? And just to clarify, hallucinations can be something that you see, something that you hear, something that you smell, anything with your senses. It doesn't have to be vision. Okay? Now, for some people, this spans a wide range. Okay? It could be they see a little puppy playing in the corner of the room, and it's the cutest thing in the world. Okay? All the way to, I see dogs trying to attack me at night. Right? So it can be scary or not scary. Generally, if it's not scary, we don't really see a need to give them a medication. Generally, I talk to them, oh, that's so cute. What's the puppy look like? What do you think the puppy's name is? Let's name it, right? And you just have a pleasant experience with them. Right? There's not, generally from my perspective, and it's not that this is the final say, but I don't see much of a need to medicate that kind of issue. Right? But people do have very scary experiences, very scary hallucinations as well. And then we try to find ways to help. Right? So that can be all over the place. Delusions, I've already mentioned, can also span to thinking that your parents are still alive when they may not be, thinking you're at a younger age when you're several decades older, all the way to the more extreme side of, someone's out to get me, the FBI is out in the car in the street, we need to do something, barricade the doors, all kinds of stuff. So it just spans the whole thing. Okay? And then some paranoia, which you could say is part of the delusions. Personality changes can happen as well. Okay? Now, what we can't get into too much today, but I will just mention different dementias as they start. Right? It can be real hard to tell one dementia from another as it's starting. Different dementias actually start with different cognitive trouble and different psychiatric trouble. Right? And the best example I'll give is that somebody with Alzheimer's disease really doesn't start experiencing hallucinations or delusions until well into the disease progress, right? But somebody with Lewy bodies dementia, that tends to be one of the first signs we see. Memory is fine, language is fine, but they see things, right? So not all of them follow the same path. And interestingly enough, as a fact, those with Lewy bodies dementia, what we find and can't explain very well, they actually tend to see more pleasant things and small things, right? So small children or small animals versus the more scary things. So just interesting. All right.
I got a question.
Yep.
Hallucinations. It's common at the end of life for patients to report visitations from family members, loved ones that
Sure.
have crossed over before them and it's reported this has happened. Would that,
Yeah.
would you equate that to an hallucination or delusion or something like that?
Good question. So our third speaker today, Kelly Davis, is asking that some people towards the end of life will report what could be called a hallucination, such as seeing previous family members, seeing angels or somebody visiting them right towards the end of life. If you want to go textbook example, then we would call it debatable. Some people would say hallucination. Others would say, how can you prove they're not really seeing an angel or somebody visiting them? So textbook, I think we could put it in the category. I don't worry too much about it because I just go with the flow and say, like, that sounds like a pleasant experience. Like, tell me more about that. That sounds really nice. And that's another example where I don't see much of a need to give a medication for that, right? Not unless it's something very frightening.
Okay, I guess as a practical matter, how do we address that with the physician who wants to medicate?
Yep, so he asked, how would we address that with a physician who would want to medicate? Sometimes it's advocating very strongly that, you know what, it's not distressing them. I don't see it causing pain. I don't see it causing discomfort. I don't see a need for the medication. And I'm more worried about the side effect that's going to come over them seeing a family member that they cherish. Right, so it tends, you have to be a little more vocal with some of them. Very good question. Okay, so what's a caregiver to do, right? This is a hard thing, and hopefully what we spend the last half as far as basic skills go. If you're family, if you're here representing family, you know them best, ideally, unless you've come in from afar as father or mother is having Alzheimer's disease. Generally, you know them best. You know their preferences, you know their history, all that stuff. I don't when I first meet them. What we try to encourage people to do from my side as a practitioner to family, I try to have them take notes. What are you seeing? And I help walk them through all those different behaviors that we talked about, right? So you're saying they're out of control. What is it that you're seeing? What are they doing? And I help refine the question. And so I always encourage people to take notes on what you're seeing. Right? My whole career is trying to find non-medication ways of managing behaviors. Right? Doesn't mean I'm 100% successful, because sometimes there's things that medication is called for, but that's my whole job. My whole job. And the way I do that is getting some good notes from what your experience is like as a caregiver, as well as when is it happening? What's going on that day? Just as descriptive as you can be. And I've had family caregivers who will have a notebook and they'll just chart it all down. And when I see them, they'll say, look, this is what happened on this date. Because what I'm looking for on my side, I'm looking for patterns. Gosh, they get upset every time this other family member comes into the house for a 5-minute visit and then leaves. Well, maybe let's work on that versus giving a medication. Right? So I'm looking for patterns is what I'm doing. So to the extent that you're able to do that, it's helpful. And then there could probably be a whole nother series that's just on resilience. How do you as a caregiver kind of get that resilience, get that armor to kind of withstand these repeated questions every day? Right? It gets frustrating, and it's totally 100% okay to be frustrated. Right? It's certainly not my intention to say, well, don't feel that way because they have dementia. Right? It's frustrating. It's challenging.
Dr. Page,
Yes.
some of us older folk, which includes me, have friends, acquaintances even, who either do not have family or whose family is far away, and we as friends and acquaintances are observing behavior that needs attention. I had asked this the other day with a Wacoa gentleman, what can we as friends, in trying to fit into what a caregiver can do, what can we do that might be acceptable? Well, let me give you a specific example. I have a friend who has only one child who pays any attention to her.
Okay.
The rest, and all of her children are far away.
Yep.
The others are long-term disintegration of the relationship.
Sure.
Okay, this one child is approachable, but does not live close enough to have a regular interaction with the mother.
Okay.
Now, I am probably the most actively interactive with this woman. I would like to be, there are some symptoms that are developing.
Sure.
That's the reason I'm concerned. I would like to be of help, but I'm not technically her caregiver.
So
what?
Yeah, let me see if I can summarize your question. So as someone who's not, and I guess I should say the word caregiver I'm using loosely because friends can certainly be caregivers. Yeah, I don't mean someone who just has to be a family member. Yeah. And so you're asking, how can someone who perhaps is in the friend position be of assistance to the to the caregiver in the home or to the person with the dementia suspected?
To the person, I don't even know what I'm asking.
Okay.
Actually. I think
It's okay.
What I'm actually asking is what connection between me as an observing and caring
Yes.
friend,
Yes.
what connection can I make with either medical,
Mm-hmm.
psychological assistance, or as a link between family
Sure.
members?
Sure. I would say, so how can someone be of assistance? It's going to vary on a lot of different factors. I think one key would be just knowing what's available in their area. So whether in Laramie or some really small other outlying town in Wyoming is going to have a totally different set of resources. But being a bit familiar with things like WICOA, the Alzheimer's Association, that can see what resources are available, because sometimes just letting them know what's available may be one way to go about it, because they're so consumed with this person's life, they don't have time to look into this other stuff. That would be one way, but it's going to depend on your relationship with them. If anything, the caring and the support is going to be the bedrock of everything else. So you are a caregiver in that sense, that you're looking after this family as a friend and guiding them and supporting them until someone's ready to get some more help. I do have lots of friends that come into the appointments with people that I see. Mm-hmm. And I would never kick them out. I wouldn't say, you're not the patient, get out. I'll welcome whoever comes with them. So if that doesn't answer, maybe afterwards I can help more specifically. Okay. Okay. So I was trying to keep track if I'm at my 45-minute mark or not. Okay. So I have this timed, and when I was practicing my timing, I was eating gummy bears, so it might have thrown off my timing a little bit. Okay. So what we're going to do the last half here is look at what I've identified, and this is just me personally, it's not the government or anything, as foundational skills. Just basic things to be aware of in the moment when you're interacting with someone who has dementia, or any kind of the dementias. Okay? From these core skills, I would argue, then you can get to the more tricky advanced, like if we had a whole nother advanced course on dementia management, but you have to start here. Okay? We're going to spend a lot of time talking about the first two, communication and approach, and then I'll touch on the others, but those top two are the most important. How you talk with someone and how you physically interact with someone can make or break the day, right? Someone whose brain is sick and they're having trouble. And so the way I've come up as a mnemonic to help people remember is I just found a way to make a word, and so it makes the word candles to kind of help people remember, but just core skills. Okay. So if anyone has seen this talk before, because I recognize some faces, I give an example about language, and I don't want to rip up my notes. Does anyone have a blank piece of paper that I can destroy? Yeah. Make sure I don't trip over stuff. All right, thank you. Yeah, I just need one. Give that back. Okay. So hear my voice okay? If I stand right here? Okay. I'm surprised by how much I'm behind the podium. I don't like doing that. Okay, so what I have people visualize is you take a piece of paper, probably bigger than this, and you write down every single vocabulary word you know. Right? And I'll give you some time. Go ahead. Go ahead, try it. No, okay, don't. But you imagine like every single word you know is on this piece of paper. What we know for most people, if you're right-handed, that vocabulary list lives on the left side of your brain. If you're left-handed, it's a 50-50 shot, so I can't help you. But it's okay. My fiancé is left-handed. So every word you know resides on the left side of your brain in something called the temporal lobe, right? And then that's where vocabulary, that's where a lot of language is. It's more complex than that, but we'll go with it for now. As you grow older, right, you're naturally probably going to not use some words that you've learned over your lifetime. Right? Unless you're someone who's fancy and you sneak in every single smart word you can in every conversation you have, which I can't do. But anyway, you're going to start losing some of those words. Okay? The classic example I give is the word onomatopoeia. Has anybody heard that word before? Right? Does anyone remember what that word means?
It's a sound that sounds like another sound.
That's right. It's a word that's spelled like the way it sounds. Okay? So you probably learned that somewhere junior high, I would guess, or high school. You learned that in English class. Okay? Has anybody used it lately?
Oh, I use
Yeah?
it every day.
Every day, every day. Oh, gosh. That's right. So you're going to have experiences like that you just don't use some words, and so they're just not going to be as readily accessible to you, simply because you've never needed it again. Okay? So already your list is getting smaller. Now, as someone with any of these dementias, and I use Alzheimer's as a classic example, which definitely has a language component, you're going to start losing access to some of these words, okay, because of the dementia. And so when they're earlier in the disease process, you're going to hear them talk and say things like, you know, it was really nice yesterday when we went to the thing. Come on, you know, right? And so they have holes, like holes when they talk. And it gets confusing because everything else comes out really nice, right? Oh, I really enjoyed seeing the what do you call it, right? And so they start getting vague. Thing, what do you call it, stuff like that. Now, they still have some words left, so they can talk around it if they have lots of vocabulary words in their head, right? This is why you should learn lots of vocabulary words. Very, true, do that. Because if I can't think of the word pen, I might be able to come up with the thing that writes. You know, hand me the thing that writes, right? And you can find a way around it. But what's happening as the disease progresses is that your list gets smaller and smaller, okay? You get to the middle stage of the disease and everything's pretty vague, middle to late stages, right? I was with someone a few weeks ago that was in the ER, and I sat with him in the ER for 2 hours, who has pretty advanced dementia. And they sat there the whole time. We have a conversation about nothing, right? And they're talking like, oh, what'd you, yeah. Okay? But they're talking, they're interacting, and they're smiling. But it comes out that way because they have a very small list. Now, as the disease really gets towards the end, just for the sake of illustration, it's very small. Now, the trouble with communication, which we're going to talk about, is if this is all they have to go off of when they talk to you, it's going to be very hard to communicate. What's on this list are very basic words like their name, maybe some of their children, sit, stand, up, down, things like that. Things that have been in your vocabulary the longest. Okay? This is all they have to tell you how they're feeling, where it hurts, when they're bored, that they love you. Right? Usually that's pretty well ingrained. But they don't have a big list. So when you try to interact with someone and talk with someone who has a dementia like Alzheimer's disease, if you don't hit a word that's on this list, it's not going to be understood. Okay? And that's what's so challenging about this. This list is very personal. What is on your list is not the same that's going to be on my list. Okay? So keep that in mind, that this is the biggest challenge with communication is it's going to get down to this point at some level. Okay? And if you keep with your fancy word of the day calendar when you're talking with them, right, you're going to completely miss out on trying to communicate and connect. It will just be confusing. Okay? Yes?
I have 2 questions that go with language.
Sure.
Is math part of this discussion? And also, for someone who has multiple languages, had perhaps, say, 3 languages,
Sure.
which were native languages,
Sure.
early
Mhm.
learned.
Sure. So her question was, first question, is math a part of this experience? That's such a complex answer to give because math relies on different brain tasks. And what I would probably say, probably not so much unless you're trying to talk about the number. The more important thing with math is that it relies on this back part of your brain called the parietal lobe. And so your ability to do it may be totally on a different level than your ability to express your answer or think about it. So there's different brain parts involved. And then she also asked about several languages and having an English not as a first language, perhaps more native. And so I definitely hear and have witnessed a number of experiences where someone goes back to their original language as the disease progresses. So certainly that will happen. Because what's happening with my paper example, you're going back in time with the words that you've learned as a rough way of explaining it. And I actually got a degree in German language, which I thought would come in handy someday. And it did not in Wyoming. But I have encountered one person that went back to German, and I was able to actually communicate with them. So all those years for that one person, it paid off. Okay, so very good question, very good question. Okay, so let me go over some details of communication, and I'm watching my time as well. General strategies. General strategies that I usually tell people, these are not going to be surprising. Nothing up here is groundbreaking that you're going to go home and be like, oh my gosh, Kyle said speak slower. I never heard of this before. Okay, so basic things. Face the person directly. The brain is sick. They need as much help as they can get to know that there's a face there and that you're talking to them, right? And that's probably also just etiquette anyway. But it'd be real hard for someone whose brain is impaired to hear me if I sit around talking like this and then I'm pointing at the side and everything like that, right? You can't hear all that. So we encourage face the person. Don't overdo it when speaking. I meet lots of people that are really enthusiastic and they really want to help someone, but they end up saying too much. Okay, remember the attention is impaired with Alzheimer's, for example. Language is impaired, memory is impaired. They can't handle compound sentences. Or, is that a word? Yeah. Like multiple questions at once or really long sentences. It doesn't get into the brain. Okay, so we try to model that for people in my work, and then we try to encourage people to make it shorter. Speak at a slower pace. Some people would say let 10 seconds go by between me asking you to do something and you doing it, or me helping. Okay, and to give a real live experience, it'd be something like, come on, put on your shoes. Okay, how many would have already just jumped in and put the shoes on, right? Right? It's hard. And this is because that picture of the sick brain that I showed so long ago, the connections are not there in the brain. There's lots of holes in the highway. And so the brain needs more time to figure out, what did you just tell me? How do I route it into the brain to the right spot to understand the word you just used? How do I route it somewhere else to then make action from it? Right? So they need time. And you'll find a lot of people will just rush in and do something, which can take away dignity. Okay? When it's simply the brain just needed a little more time. Okay? And then there's just some other points. let me just mention this other one. Easier said than done. Use a friendly tone when possible, even when you're frustrated and you're ready to rip your hair out. Okay? As much as you can. And the reason for this is that even though language may decline, they may not understand your words and they may not be able to give you words, you can still process nonverbal stuff. You can still process emotions and social cues, right? That stays around for a while. And so all they're going to get is you keep telling me something that I don't understand and now you're upset. Okay? You might be upset about something completely different. Maybe the bank won't respect your power of attorney for financial stuff, right? You're not the person. You come home, you're mad, right? They're not going to sit there and be like, well, she's probably mad about this other thing. It's probably okay. It's not personal. They just feel it as personal. Okay, so that's where that recommendation comes from. All right, so none of those are surprises. Now, what happens is that doesn't happen every day. Okay? It's hard to make that happen every day. When you get frustrated, when you get stressed, when you get busy, when you get tired, the basic skills of communication fall off. Right? And they already have brain trouble, so they need all the help they can get to understand. Now, if you're like, Kyle, I don't want to change anything what I'm doing. Right? I don't want to add friendly stuff and speak slower and always smile the whole time. You're ridiculous. What I would then say is, all right, promise me you'll cut out these three things. There's a good amount of research, more for like nursing home environments, that if you cut out these three things, it actually goes a long way in helping someone. Okay? First thing, cut out statements that add pressure. And what I mean by that are going to be things like, come on, you remember, don't you? You know this. You remembered it yesterday. Come on, Dad. Right? If they remembered, they would remember and tell you. And so those are that adds a lot of pressure to someone. And what I know from the cognitive science, like the harder they try, it's not going to work. Like my number one recommendation to those I work with dementia is let it go. Just relax. It'll come to you, right? Don't try hard because it actually places more stress on the brain. Okay? So we try to encourage people to take those out of their vocabulary or just your language that you have. Okay? The second thing I would ask, take out anything that's going to correct the person. Okay? And these are going to be things like, actually, I think there was an example with Dr. Wood's presentation, like someone was talking about, no, Mom, that's not how it goes. It goes like this. This is the way to do it. Okay? If they knew that, they would do that. But they cannot do that. And so, again, it adds more pressure too anyway. But we try to cut those things out where you're like, no, that's wrong. That's not how you do it. Okay? There's a lot of just family stress and arguments that happen by just trying to reason and correct someone who has dementia. That's never going to get corrected. Right? So I encourage people just to cut those out. Cut those out. Okay? And then the last thing are statements that discount the person's experience. Okay? Kind of related to the others too. But here is where we get into hallucinations, paranoia, and things like that. Right? If this person thinks they see a dog over in the corner, there's no reason for me to tell them it's not there. Right? Even if it's a scary dog and it's trying to attack me, telling them, no, there's no dog over there. Oh my gosh, they're in tears because they think they're being attacked. To have you come up and say, nope, that's not right, you're wrong. Right? That totally discounts their experience. They're very clearly experiencing it as real. And how confusing it is for them, how frustrating, and how it kind of devalues them for a family member, someone that they love and they trust, to come up and say, that's not happening. Right? So we try to find ways to encourage family, caregivers, friends, all staff to take that out of how they speak with someone. Right? It gets a little trickier if it's something like, I think you're cheating on me with the neighbor next door. Right? You're not going to be like, yes, I am. How does that make you feel? Right? Right? It gets trickier with something like that. So don't apply it all. But for most of the time, it's going to apply when they think that their parents are still alive. Right? I don't correct people. Right? I don't correct people. I go with it. Okay? So promise me at least those things.
So if the person is having
Yep.
a negative hallucination, something scary, they're being attacked, do you help them find a safe place or
Yep.
feel safe in those situations?
Good question. So she asked, what if the hallucination perhaps is scary? How would you intervene? So again, a very tricky thing that depends on each person, but the ways that I have done that is I still go with it. And probably the best example for this setting I would give, we did have a gentleman once in all the places that I've worked who did see dogs attacking. That's where that example comes from. Every night when this guy would go to bed, we'd see dogs attacking him and see and kind of feel it. And it did me no good the next morning to be like, well, that didn't happen. Right? Was it a dream? Because I was curious if it was just a nightmare. Nope, it was real. It was real. Okay? So the way I worked with this gentleman is I said, that sounds really horrible. That sounds like a very scary experience. I validated the feeling. I validated their experience. And then I tried to take on the responsibility. You know what? Is it okay if I look into that? If I try to do something, can I talk to some people for you? This gentleman in this instance said, yes, please help me. I don't want dogs attacking me. And what we had done is I pretended to go talk to someone to be like, no dogs are allowed to visit at night anymore for this guy. Right? And so I told him that. And then we also came up with a plan to make a big sign that had a picture of a dog with a big red circle crossed out. It said, no dogs allowed. Okay? Kind of like the classic, no girls allowed in my fort. It was just like that. And I went with him and said, look, I think this might work. Right? So I'm positive about it. I think this might work. I've talked to some people. How about we try this out? Okay, let's put it up. Put the sign on the door, and then it never happened again. Okay? Does that happen every single time? Gosh, no. Gosh, no. But those are the ways that I try to find a non-pharmacological way, so a non-medicine way to help with the hallucination. Because you could easily just give him what's called a PRN, a medicine that will knock him out to sleep. We try to find another way to do it first. Okay? Yes?
That sounds like a great situation. And so when I think about these scenarios, I think the partners that might have trouble coming on board with that might actually be the care partner or the family.
Mm-hmm.
And so how do you talk about that and also hold the dignity of the person with dementia and say, how do you bring them along?
Sure. So she's asking, and make sure I summarize this correctly. You envision people having a real challenge with this would be care partners, family members, and then how do you help them with this experience while maintaining dignity? Did I get that? Okay. Yeah, so that's my whole job. Is it's not like I can just have this presentation, everyone's going to go home, and you'll be wonderful at it, right? Right. I'm hoping I'm building you up and feeling great about it, but it's really hard. And so in my setting, which is not throughout the whole state, and it doesn't have to be a psychologist, but I work with them weekly. We talk about this, and in real life, I have the couple together with me, and when this happens, I show them how to respond. And so I do a lot of modeling myself. Now the trouble is I don't exist throughout the whole state of Wyoming. And so we try to find other people who can be educated about that, trained on that, to then go out and help families. Real life, it can't just be my presentation. I have to show them the skill. And that's what I find works best for me in my setting. So it's just modeling, a lot of modeling. So that's a harder one with Wyoming. Okay, so what I'm just also watching the clock. What I've listed in your packets are different ways to change your communication style based on the level of the disease. It's not enough to say, okay, I know they have dementia now, so I'm going to talk differently. Okay? That's great if you're doing that. You're on the right path. But you have to keep changing your language in your communication as the disease progresses. Okay? And so what I've listed for your packets are just different kinds of tips, tricks, strategies throughout different stages. So in the early parts of the disease, generally you don't have to change much. Okay? Maybe it might just be some mild memory trouble. If it's Alzheimer's, you write some notes, you kind of find a calendar on the refrigerator, all kinds of stuff. So you just support them. But the language piece with Alzheimer's specifically will then come usually after memory starts appearing. When you get towards what I would just call the middle stages, so several years into it, we usually have to get shorter. Shorter sentences, more direct. We can't have that big flowery language. We can't be abstract or things like that anymore. We have to be more concrete so that there's no misinterpreting what we're saying. Okay? Rely less on open-ended questions. Right? You want to promote dignity and you want to have them be a part of this experience, and so you might be asking things like, well, where do you want to go for dinner? What do you want to wear today? Right? If their brain is sick and they're having trouble, it actually can be very hard to come up with an answer. Very hard, and then it gets frustrating. Okay? So as the disease progresses, we encourage people to just offer options. Okay? Hey, do you think you want to go to, I have no idea what's in Laramie, Chili's or McAllister's, which are just right over there. And you just offer it. Right? And you're not just randomly picking restaurants, but you're picking things that you know they like. And then they can more easily participate in the decision process. Okay, so we find ways to tweak that over time. And then towards the end of the disease, the ones that I'll just point out, we use very few words because of our list that's on the floor up here. We have to be more short, more concrete, simple words, up, down, sit, sip, swallow, that kind of stuff. Okay? Try not to have a long, drawn-out sentence. Okay? More visual and tactile ways of communicating. So there might be other ways, depending on the dementia, to get around the verbal piece. Okay? When I was interacting with someone who was having stomach pain, and I asked him, is your stomach hurting? What? No, I don't know. Right? And then when I point to his stomach, I tap it. Your stomach. Yes, hurts. Hurts a lot. Okay? So you have to find other ways that are all based on what comes out of your mouth. Okay?
Dr. Page?
Yes, sir.
In this list of progressions, I guess maybe early to middle, you had mentioned earlier about social problems being in social context.
Sure.
Let's say that you have a person you're giving caretaking to who had always liked to go out to eat, liked to go do X, Y, Z, go to a movie. As this and you're at a point where you don't want to ask them X or X. You don't want to be pushing them to make a decision.
Sure.
Does it generally work okay to go ahead and take them to places that they have enjoyed?
Sure. And so the question being, as the disease progresses or at different stages, rather than asking and offering options, can we just take them somewhere? Yeah, it's going to depend on each person. Some people really value being a part of the experience of deciding, and they know when you don't include them. So this is more for that kind of individual. I've met tons that are just pleasant and they'll go with whatever you say. And so you definitely could just take them to a place you know they like, right? So you're agreeing with their preferences and what you know about them from history. So you definitely could. Usually the challenge comes up is if there's any concerning social behaviors in the restaurant. Like, are they going to throw something or yell at someone? But that's usually the challenge. Okay. With communication, we always want to make sure we mention, we're getting very task-focused, like how do you help them do this or make a decision. But don't forget, how do you express appreciation, respect, love, things like that in your everyday encounters, right? Don't get too caught up in what I'm saying about language changes, and you have to be careful. That's usually when you're trying to get them to do something or asking them to do something. You can still have a complete conversation with them if it doesn't seem to upset about nothing. I have many conversations with individuals. I have no clue what they're saying. They have no clue what I'm saying. But you know what? We go back and forth, right? And I smile the whole time, and they have a great experience. Okay? So you're going to find your ways to still do that. Still say you love them, thank them, show ways that you care. Okay? Could I get a time check just so I know? How many do you? Because we started late. 10 minutes, okay. The other piece that I'll mention in the candles is approach, the physical approach. And so most of the emphasis is on communication, so that's where I wanted to spend most of our time. But there's also something to be said about how you just walk up to somebody. Okay, remember the brain is sick, the brain is impaired, it can't think quickly. If you just quickly walk up to someone, right, their brain might not have enough time to know that you're walking up to me, what do I do about it? Right? It can be startling. Also, as the dementias progress, their world becomes smaller. And towards the end of the disease process, their world is their bed, is the chair that they're in. They have no clue the TV's on. They have no clue that someone's in the kitchen cooking. It's what they can reach. And so if you all of a sudden out of nowhere come up and touch them to give them medicine or something, or to help them up, that really can frighten them and scare them because somehow you just popped up into their world. Okay? So we try to go from the front when you can, go at a slower pace when you can. Be careful of all the nonverbal things that you're showing. I find some way to let them know I'm coming. Jingle my keys, my feet, I walk a little heavier, cough, say their name, something, so that the first time they know I'm in their world isn't me touching them. Okay? And one that I see a lot, just to kind of point out there, to the best of your ability, don't grab somebody from behind, pull a wheelchair back or something like that, because they don't know that you exist and you're behind them. Okay? So it's very startling. All right, so those are just basic things, and again, most people would say this makes perfect sense. Okay, fine. But I'm trying to tie it back to some of the brain impairments and where those recommendations come from. The N in the candles approach stands for needs, right? So when you're thinking about what's going on with this individual, how can I help them, think about their needs, right? We do that naturally already. Some people are just a really caring kind of person, so you're not going to have trouble with this. But it's still a physical need. There's still a social need. There's still a spiritual need, emotional need. That stuff doesn't go away. Right? We just have to find another way to get at it with them. Okay? And maybe a nonverbal way. And so it could be some behaviors come up simply because they need the toilet. They need to go to the bathroom. But they can't tell you with words. So sometimes the behavior of throwing something could be, I need help, but they can't find a way to say it. Right? So we're just trying to be detectives in that sense of what could they need or what. Okay. D stands for distraction. This probably, I keep saying this every time and it's true, probably needs to be its own 1-hour presentation on how do you distract someone with dementia. Right? Can't do justice in this, but what I would point you towards is distraction doesn't work if you don't have their attention, right? They don't know that you're there. And if you kind of miss the mark for where they're at in their disease. And what I mean by that is I'll see some people, maybe someone is being repetitive, they're saying the same question over and over again, and we want to distract them. Okay? I see them come in with like a coloring book and be like, here, let's color. Okay? That might work for someone, but gosh, if they're not that far in the disease progress, that's going to be insulting. Okay? So that's a real hard skill to learn is how do you match based on their history, who they are as a person, and what level of the disease that they're at. But it only works once you have their attention, or it doesn't always 100% work. You have to have their attention, And you have to validate the emotional experience they're having first. If you walk up and someone's upset and crying and you offer a coloring book, completely invalidates that they're crying. It ignores that they're crying. And so you try to find ways, you seem upset, you seem sad or something like that. And then from there, you try to work on distraction. But it can't be something that's completely off the wall, left ballpark kind of thing like a coloring book. The L stands for leave for later. When you're thinking behavior management, things to think in the moment, there's a lot of things that don't really need to be done when you think it does. Okay? It's real easy when you're busy and you've got to get to the bank, you've got to get to the doctor, you've got to do X, Y, Z with the grandchildren. You've got a list and you're making little checks on your list, right? But what that causes is friction between the person who has dementia, right? How important is it that they put this new shirt on right now, right? There's a lot of fights that happen. It's because, no, we need to go to the doctor. You're putting this shirt on. I don't care if they have the same shirt from yesterday, right? There's some things that can simply just wait. Try again later, right? Now, this doesn't count for things that are emergency situations, right? If perhaps they're incontinent and they won't let you change them. You can only go so long and say, well, Kyle said leave it for later, so next Friday I'll come back around, right? So it doesn't count for those kinds of things. Like sometimes you just have to do what you do and hope to reduce the distress as much as possible. Do something pleasant after it. Okay? Sometimes you just can't get around it. But this is just a note to just say there's a lot of things that actually don't need to be done at a certain time. Just go with the flow, leave it for later, come back later, and ask again. Okay? And then the E stands for environment. This is, again, a bit of a detective experience. There's a lot of things in the environment, and this time I really do mean the environment, like heating, sound, noise, all that kind of stuff that really can cause behaviors. Okay? It's easy to be like, well, they have dementia, so that's probably the behavior. Let's give them a medicine. I've had tons of examples where the family is fighting about something totally unrelated. This person with dementia can't process what's going on. He just sees the family fighting, is upset. Get dementia behaviors, and I've seen them medicated for that. Okay? When you don't want something like that. But it could be something so basic that they're cold, right? So we want to be thinking of those kinds of experiences. And then the S stands for senses, which is just promoting sensory experience as much as you can. Eyeglasses, hearing aids, if they'll let you put them on, give them the best, give their brain the best possible chance to hear, see, and understand what's going on. And going back to the light question that was answered earlier, or asked earlier, if someone has trouble sleeping, because that does happen with a number of the dementias, yes, there have been tons of studies that look at light therapy to help someone, so that definitely is supported. What I do also, because I don't have these fancy light boxes, is if you're going to give them melatonin to try to help with the sleep, also do these other issues. Turn the light on during the day, open the blinds, open the window, right? Something that promotes its daytime right now. Your body takes a lot of cues from those kinds of things. And so don't forget to do that piece as well. So in that sense, yes, light is something I actively try to work on. Exposure to light, natural light if you can. Okay? So that's brings me towards the end. Dr. Woods put the websites actually on her presentation for some of these things. You can actually just search these online and you'll find it. But there's a wealth of resources very specific to behaviors, very specific to communication that come from the University of Wyoming, the Center on Aging, Alzheimer's Association, all these other kinds of associations for other dementias. If you're talking about someone who's a veteran, there's a whole other class of services that are available for veterans out there if you're enrolled in the medical center, and as well as the National Institute on Aging. So I just want to make sure there are a lot of things out there, but it's hard to know that they exist. It's hard to have time to go find them as well, right? And so we're trying to think of all kinds of creative ways to address that. So, all right, and then those are just the final points, which I don't have to read, but just the summary of everything that we talked about. Okay, thank you.